This is a fun list of people's Troy put on here. Dr. Phillips, I went to medical school with her, and Joni Steffens, you know her, and I know her husband. So we got the whole list on here, so that's exciting.
All right, so announcements really quickly. Remember, there's free CME. Make sure that you fill the things out when they get sent to you, and you will get that credit.
Please chat us in if there's more than one person in your room, like Brittany put Mickey's name in there so she gets the credit.
Free.
And videos on would be super.
Yeah. Again, always love to have the videos on just so the speakers feel like they're talking to people. So don't be afraid. Again, we got a lot of upcoming things next week. John Cole from Hennepin Healthcare is coming on the Wednesday Echo to talk about his experience as a toxicologist and ER doctor. That should be fabulous.
And for those of you who may remember early on in the COVID Echo, he gave his firsthand experience of having COVID himself, as well as what he was seeing in the Hennepin ER. So he's a great speaker, just to make that connection.
Yeah, we are having a little talk on the Tuesday Echo coming up on motivational interviewing and lapse and relapse. So feel free to join us for that as well.
And this is not long-term surveillance. This is opioid use and all of that for older adults.
All right, again, technical assistance. If you need to get hold of us for anything, Erin's number's there. You can reach out to her. You can see her on the screen right now as well. And then our phone numbers are there. So reach out if you have questions about any patients with addiction that you have concerns about that you need help with.
Online website. This is going to be hopefully perfectly amazing and done and everything there by the end of the month.
We will see.
So it'll have all of the forms, all of the everything on there. There will be a big push announcement, but that's how you can get on the Echoes, how you can find the patient case form to present.
Yeah, and the Addiction Connection podcast, again, just released one on sugar.
Part 1 on sugar addiction.
On sugar addiction, which isn't truly an addiction, but it's very interesting.
When it's a whole chapter in Sam Quinone's book, The Least of Us, it's an addiction.
Are you going to bring that up?
Yes. Haven't gotten official permissions, but I'm going to do it. So, oh yes, after Midsummer, this Echo is literally not going anywhere ever, just so y'all know. The Tuesday Echoes will be done at the end of September, so that is the end of that one. But the Wednesday ones will definitely keep going, which brings us to November 2nd, Wednesday, November 2nd. Please, please, please mark your calendars. Sam Quinones, who is the author of the amazing, amazing book Dreamland, which literally gives you the entire background of the opioid epidemic, with his second book, The Least of Us, which is everything fentanyl / meth / all of it. He's a nationally known amazing human, and some reason he thought we were cool enough to come. He is going to present on our Echo November 2nd. So that'll be a big one. Tell your friends. You will see more information about that in the next coming weeks.
Okay. On to Troy. Go ahead.
Oh, the survey. There's a survey. You'll get it in your emails. So there you go. So we would like to introduce our speaker today, Troy Rubberbaum. They are a licensed marriage. I always get all these letters mixed up. Licensed marriage and family therapist out of Center Care in the LGBTQ plus clinic. And this is such a great topic. We're so grateful that you agreed to present for all of us. And if you would love to, I will take our slides down and you can bring yours up, Troy, and then introduce yourself even more would be fantastic.
Okay, so I'm going to share my slides.
You're muted.
No, he's not. No, they're not. We just can't hear.
Can you hear me?
Uh-oh. Audio doesn't seem to be connected.
Okay.
I can hear you. Can you guys hear me?
Katie unmuted, so she
can hear everybody.
I can hear him.
Maybe.
I think Kurt and Heather have the problem.
Oh, you can hear?
Yep, I can hear him.
Oh, now we can hear.
Now we
Sorry
can
about
hear.
that.
All right. Sorry, Troy. That was all us.
Oh, that's okay. I'm technologically challenged, as I was telling somebody at the beginning of this presentation. Now I can't figure out how to get rid of the bar that's covering up the slideshow.
Katie, can you help?
Sorry, you're trying to, if you click on the slideshow button.
That's what I'm trying to do, but it's covered up by a task bar.
Oh, if you double click on it and move it. Like if you double click and then drag your mouse. Otherwise, I'm just seeing here if I can, in
Very
your bottom right,
screen.
Oh, yep.
Yeah.
yep, down here on your bottom right corner, there are those little
Mhm.
icons. There's like 4 squares and like a book. Bottom right corner with like a percentage scale.
See with, yep, I see that.
So if you
Okay,
click
and then
the
click-
one that looks like an old screen.
Yep.
Next to the book, that one.
There, okay. Well, it takes a village, right? Well, thank you for your help. I was talking beforehand about the technology aspects of the mental health field, and really, quite honestly, it's interesting that it's not a huge strength of mine, because with the transgender population, it is a huge strength of them, because this is how they're socializing, this is how they're interacting, that's how they're getting their information, because it's safer to do so online than it is to do it in interpersonal relationships that may not be supportive. But yes, my name is Troy Weber Brown, and I use they, them pronouns. And I have been working with the Sexual and Gender Medicine Clinic with Centric here for the last 5, going on 6 years. And before that, I worked for a dual diagnosis program called Pride Institute in the Twin Cities. I was their clinical supervisor. And before that, I worked for an adoption and foster care agency developing curriculum for parents and foster parents that were working with transgender youth. And then before that, I had my own agency, which was also dual diagnosis, but it was outpatient. So that's kind of my history in this field that we're talking about today. So I am the only one presenting, even though our care team, which is listed, consists of a multidisciplinary team of medical doctors, medical providers, as well as we do have nursing now. Jamie Fox is with us. And then Katie is our patient navigator, making sure that in the surgical preparation process that people don't necessarily fall through the cracks. So our goals for today, and I think that I may need to be brief, and I'm always open to follow up if people need greater explanation or clarification of any of the things that we talk about. But I do want to get you the information available in the slides, at least to throw the information out there, and then to leave some time hopefully for questions if people need it. But I want to talk a little bit about what brings people into treatment, or what brings people to their addictions and mental health concerns. In my line of work, I don't see them as separate things. I think addiction is a coping skill for a mental health problem. And so I don't treat them as separate things. I treat them as coexisting conditions. We're going to talk about ways that the medical profession is set up to make it difficult for trans people to feel safe. And so therefore they don't necessarily feel, or if they're not safe with their provider, then they're less likely to follow through with treatment recommendations. And then things that we can do to help increase culturally competent treatment planning and engagement from our transgender clients. So the first thing I want to talk about is just the reality that everybody has identity. So sometimes I think when we talk about transgender people, that word transgender puts us in the mindset that, oh, this is something different. This is something that pertains to them. And it isn't, because we all have identity. You know, my gender identity is non-binary, but most people, or I would say, you know, the majority of people identify in the cisgender realm, which is having a gender that matches the sex that you were identified at birth. And then, of course, the people or the population that we work with and that we're talking about, transgender, are people that are born or identified one sex or gender, but that's different than the gender that they currently identify with. But that's just one of many identities that we have. Our gender is just one. Our age provides an identity, and our ability status, whether we have a disability or we are able-bodied, that's an identity. The level of education that we receive, that's an identity. The jobs that we hold, it's an identity. Our hobbies, our sexuality, all those all of these things are different ways that we have identity. So the reason why I bring this up is because to interact with the transgender population in a way that connects to the fact that we all have identity takes a little bit of the emphasis off of them and shares that with us and creates more of a trust in that relationship. So in particular, what is gender? So when we're talking about gender as an identity, one part of gender is, the identity, which is an internal sense of who we are. Oftentimes when I'm working with people, what I like to do is ask them to close their eyes and picture themselves in a completely empty room. No chairs, no bookshelves, no carpet, no windows, nothing, just themselves in this black void. And then I would want them to kind of look at themselves and tell me whether or not they're thinking about their gender. And interestingly enough, in 23 years that I've been a gender therapist, I've only had 2 times where somebody said, yeah, I'm thinking about my gender. The rest of the time, they aren't. And to be fair, those 2 times they were neurodivergent or people on the autism spectrum. So they already have embedded difficulties in abstract thinking or abstract thought. But so the reason why people typically aren't thinking about their gender when they're in an empty or a void space is because gender is who we feel we are in relationship to other people. And because of how we feel about who we are when we're in relationship to other people, it informs how we express our gender, the clothing we wear, the jewelry choices, hair length, things like that, activities we like to participate in. We choose those in order to get other people to help us gain access to typical spaces that our gender has access to, or to use the right pronouns or use the right name, things like that. A lot of times our expression also gets other people to allow us to act as the gender we associate with. For instance, how many times in common social situations do females have the space to share freely and as much as they want? Typically, that's a male norm, not necessarily a female norm. So those are the kind of things that, in particular, trans males want, is access to taking up as much space as a typical male would take. So gender is not a concept that just one day appears and exists just in the mind. It is a process that starts at conception and continues for the rest of our lives. So for instance, when we are conceived, everybody is a female. Genetically, they are female. So we just have an X chromosome, and we're that way for the first 7 weeks after gestation. And then at 7 weeks, we are given a secondary chromosome. If it's X, our body starts to develop or continues to develop as female. If it's a Y, then our body changes trajectory and the female body parts start to either change or wither away, and male body parts are then developed. Now, I hope that you caught on to the fact that I was very clear about saying that chromosomes affect body development. Because at 12 weeks is when the womb is flooded with a primary hormone. And that is what helps the brain develop in terms of gender. So if the primary hormone is testosterone, then the brain develops as male. And if it's a primary hormone of estrogen, then the brain develops as female. If it's any other form of hormone like progesterone or all the other ones, then it could be any kind of non-binary identity as the child develops. So body and brain, scientifically, it's been proven that they develop separately. Well, the baby is then born, and at that point has no brain functioning other than in the limbic system to get their needs met in terms of their basic needs, food, changing, comfort, things like that. And so it's the brain's process process to start developing these neural pathways slowly over time to give the baby more and more functioning, walking, talking, those kind of things. But part of that developmental period happens between the 6 to 10-year-old range that pertains specifically to gender development. And that is when the brain develops the neural pathways that allows us to be able to understand gender, not necessarily in the sense that other people tell us what gender is, but we have an internal sense of what gender is and how that pertains to us. And then in 6 to 10 years old, just shortly thereafter, or during the tail end of that developmental cycle, then puberty starts, and it becomes very clear to somebody who has an internal sense of their gender, whether or not their body is developing according to what their perceived gender is, or if it's different. So during assessment, there's a lot of exploring of those life stages, and then trying to figure out whether or not during those life stages, that's when increased behavioral and mental health conditions exist. So I think it's important to understand that gender develops physically, and because I think the more popular belief is that there's just a decision that gets made someday about what gender is, and then people decide to go through a lot of intensive medical and surgical treatment to change the way that their body is configured. This is a tool that is in our offices, and I think it can be used in your offices if you feel like this is the best tool for you. But it serves two purposes. It helps us have this conversation about what is gender identity and what is not gender identity, because I think in our society we talk more about what gender is not than we talk about what it is. For instance, if we separated gender expression, the clothes we wear, the activities we like to participate in, and we took out the sex that we're assigned at birth, and we took out who we are sexually and emotionally attracted to, we've just functionally taken away all of the conversations that socially we're having in regards to gender. So one, it's a tool that helps us have these conversations to separate out what is gender and what is not. But the secondary thing is that if somebody sees this, because it's very well known within the transgender community, they're going to feel more safe, and they're probably going to get the impression that the provider that they're talking to has some ability to understand where they're coming from and therefore culturally treat them appropriately. So some terminology. So on the sexual orientation part, there's lesbian, gay, bisexual, pansexual. Those tend to be the more popularly used or the more commonly used identifiers. Lesbian is just a woman attracted to another woman. Gay, man attracted to another man. Bisexual could be anybody attracted to any other sex. or multiple other sexes. And pansexual in particular is less about sex and more about attraction to a person. So personalities, usually there has to be an emotional attraction first before sexual attraction follows. And then in the gender identity, we probably have more identity terms for gender than we do for sexual orientation. But the ones that you might hear the most commonly are transgender, which is somebody who was identified as one sex at birth and then became aware that their gender is different than that. Transsexual, we don't typically use this term. The community does not use this term, but it is an older version of the medical term that identifies that somebody is changing from one sex to another. Now, to be fair, transgender being used by the community in the way that I defined it is not necessarily what you're going to see when you look it up in a dictionary or what you're going to understand when you have these conversations within medical communities. What you're probably going to hear about the term transgender is that it's an umbrella term that pertains to anybody that falls outside of the typical social norms for gender within that society. So for instance, if a male has longer hair, transgender would apply to them. In a society where short hair is the norm for males. Somebody who dresses up in the opposite gender's clothing for performance purposes, otherwise known as drag kings or drag queens, would fall under the transgender umbrella. So transgender is a very broad term medically and according to definition, even though the community is using it primarily to identify their experience of their gender being different than the gender that other people perceive of them. Non-binary and non-conforming are kind of synonymous with each other, but it's just somebody that doesn't necessarily feel that they exist within a binary of male and female. And it's a misconception that people on the non-binary continuum are androgynous. Very few, including myself, I present very male, but I identify as non-binary. So non-binary is less about presentation and more about whether or not one feels like they fit within a male-female binary. So sometimes non-binary people will exist in between, like they feel a little bit of both. Sometimes they just won't feel like they have either or both. And the last one is demi-boy, demi-girl. I put this next to pansexual because it goes really well with pansexual in terms of a demi-boy or a demi-girl, or a pansexual is somebody that has to develop a close personal attraction to somebody before sexual attraction follows. And demi-boy, demi-girl is the same thing. Their sense of their gender only exists within trusting relationships. So those are just some of the terms that you might come into contact with. So in terms of what are the numbers of people in the United States and in Minnesota that identify as transgender. I have put the statistics up here. I'm not going to address them, nor am I going to talk about them in great terms, just because I kind of think it's all bunk. And here's the reason why. Being transgender is a concealable identity. If I didn't tell you at least a couple of times in this presentation that I was non-binary, you wouldn't know. I can conceal it. So if I can conceal it and I go into a research study and I'm asked, is your gender male or female? I could say male. And I wouldn't be counted as a part of that statistic. So keep in mind that the statistics are out there as a guideline to help us understand or get closer to understanding, but not necessarily infallible and telling us the true numbers of transgender people that exist in our country, in our state, in our counties, in our clinics. The only way to really make sure that we are aware of whether or not or how many people we serve that are in the transgender community is make sure that your environment is safe, make sure that you are safe, make sure that your environment is set up with imagery that lets people know that they belong and that they're welcome there. And then make a part of your assessments and initial conversations or consults, verbiage asking about gender, and try to shy away from verbiage that implies that it's male, female, or other. Sometimes just hearing somebody say the words transgender, non-binary is very comforting and safe, and people are more likely to divulge. The things on this slide that I do think that are very important to identify is that we live currently in the 12th largest populated state overall in general population, not just transgender. We are the 10th fastest growing population of LGBT identifying individuals, and also the 10th fastest growing state in our general population as well. So the number of transgender people are going to continue to increase, and we have a decision to make in the medical community. You know, as the population rises, do we keep our level of services down here, or do we raise them to meet the population's needs? And my hopes is that more clinics will increase the level of services that are provided to this population to meet the population's needs. So it's not easy for the transgender population to connect with medical professionals. They come to us with a varied history, and usually a very negative history of interactions with providers that disagree with them, want to invalidate them, refuse to treat because of a transgender identity, and many more. In fact, research identifies that not only do people experience invalidation, but there's also issues of mistreatment and violence, not only in the clinical setting, but in their lived lives outside of medical environments. And so I think it's important for us to know the history that our clients are coming to us with, because the unfortunate reality is that when they come to us with those histories, it's going to be our job to help rewrite that and to show them that their experiences within medical communities can be different. So in terms of their lived experiences, transgender people are more likely to attempt suicide. They're more likely to have severe psychological distress, and I include chemical dependency in this situation, which makes sense to me because if it is the way that the human brain is set up, that if you are in pain, and it doesn't differentiate between physical or emotional pain, if you are in pain, you want the quickest way out of it. If we touch a burner that's been on, instantly we pull it away because that's the fastest way away from the pain. In terms of psychological distress, the quickest ways out of that psychological distress is pills, alcohol, smoking substances that alter a psychological state, or suicide. That's the quickest. So of course, these are the lived experiences, or these are the choices that transgender individuals experience because of their increased risk. They're also more likely to be unemployed, living in poverty, HIV infection, and have intimate partner violence perpetrated against them. My personal belief is that where this all boils down to is the negative social messaging that gets played out in these different environments. So for instance, intimate violence, intimate partner violence, if there is a devaluation or invalidation of transgender people as a popular belief in our culture, then when people are in relationship with a transgender person, they will be devalued as well. People living with HIV, if you cannot get adequate sexual health care from a medical provider, you're still going to get your sexual needs met. And without protection and protecting yourself, it's going to increase your risk for sexually transmitted infections. So what are our clients' specific experiences within medical care? 50% identified of this study identified that they walk into the room with you anticipating that you're going to discriminate against them because they have been refused healthcare. They've been blamed for their healthcare state because of their gender identity. They may fear providers are inadequately trained. And quite honestly, unless you've gone through a more current medical program, you probably went through a medical program that did not teach on transgender care specifically. And so therefore you would have to get your education through continuing education units, or I think you guys call them CMEs, correct? But a lot of times they get talked to by providers in very harsh and negative ways, and so on and so forth. So you see there are some things that our clients come into our care already experiencing that are very negative, and we have to help rewrite those experiences for our clients. As a mental health provider, I realize that I call the people that I work with clients, and the medical people on my staff, they call them patients. So hopefully, as I say clients, because that's what's normal for me to say, you can translate that to patients. So how do we rewrite or create a different experience for our clients? I think it's about providing and protecting our clients' safety. That might be telling them that they're safe in our communities or in our clinics. It might also be by putting up things in our environment that lets people know that our services are for people with a female body or a male body, because no matter what people identify in terms of gender, our bodies have two configurations, a female and a male body. Within our medical practices, we try to remove discriminatory barriers in care when our colleagues are derogatorily interacting with or communicating about their transgender clients, that we be a champion for knowledge or champion and ask for our staff to show more unconditional positive regard for this population, using correct pronouns and their names is probably the single most important thing that any clinic can do in terms of helping clients feel safe in their environment. So include gender and holistic assessments. We talked a little bit about this before, meaning that when you're doing your assessments for treatment or treatment planning, that you talk about gender, you talk about the ways that their addictions or medical conditions are impacted by their gender incongruence. And then also utilize gender-related best practices. And I think this is what I was referring to in terms of like seeing people as female-bodied or male-bodied, not necessarily gendered, but female-bodied, male-bodied, because most medical practices I'm learning from interacting with the multidisciplinary team are more attached to the organs and body configuration of those two body types. Creating a safe space in our clinics we talked a little bit about this already. Don't tolerate mistreatment and discrimination by staff towards patients or visitors. You know, if we have front end staff, educate them on how to positively and effectively intervene in a situation where somebody, when there's two people in our waiting room and one person is being derogatory or making it unsafe for our transgender patients to be there. Affirm people's identities and lived experiences. I think at the beginning of this conversation, Heather, you had gendered me very correctly by using they, and then you mistakenly said he, and you corrected yourself and moved on. That is exactly what we want everybody to do. You know, mistakes will get made. We are socially conditioned to look at somebody, and if there's male identifying characteristics, we just say he. If there's female identifying characteristics, we just say she. So it's going to happen. We're allowed to make mistakes as providers. The thing is don't make it about us. It's about the other person's gender. And so if you do make that mistake, like Heather did, sorry, change it, move on to the rest of the conversation, because ultimately the other parts of the conversation is what your clients are there for, not necessarily to have extensive conversations about the mistake that just got made. You know, sharing information the right ways with the right people at the right times, not always is it appropriate. You know, when we were doing case consultations or seeking help from other people in treatment options, for us to divulge that our clients have a transgender identity. Just make sure that when you do share, it's clinically important to share that information in a way that gets the right treatment planning and treatment options. And we already talked about creating the environment that says we care for all people. One ways that we do it and other clinics have done it is, like an example of that would be, you know, if there's a flyer in the waiting room that addresses like breast cancer screening, make sure that trans men know that this pertains to them and that that our treatment is for them as well. And for, in the same vein, I think, you know, for trans women, if there's a like a urology clinic would do prostate exams, make sure that trans women know that that still pertains to them too, because of their male body, not their female gender, but their male body. Removing barriers for discrimination. I think it's important to acknowledge personal beliefs, but not necessarily make those beliefs go so far as to create assumptions in the clinical diagnosis and treatment process. I think when we are free as clinicians, when we're around other clinicians, to say, I disagree with that, then it opens us up to hearing feedback about how we can prevent that from getting in between the relationships that we develop with our clients. It's okay to have personal beliefs. It's okay to have assumptions. It's okay to have biases in our personal life. I think when it comes to working professionally or medically with people, we have to figure out a way, somewhere to put that so our clients get the best care that they can get. So we don't provide those barriers to care. Critically analyze policies, procedures, and practices. I don't know if we're a group of medical providers or if we also include some support staff, but this might be something that the support staff that we work with get engaged in terms of how do we look at our paperwork to make sure that people know that we know that they're there, and what does our environment look like, and sharing of information and things of that sort. Address people by their correct name when interacting and speaking with them. We just talked about that, and then also the pronoun use that we also talked about. Again, I just want to emphasize it's okay to make mistakes. Correct yourself, apologize, and move on as quickly as possible. Assessing gender history. In our clinic, we assess it in 2 stages. We want to assess gender identity and we want to assess sexual orientation. That does 2 things. It helps us keep it clear clinically about what we're treating and how treatment should be proceeded, but it also sends the message to the client that we see you as who you are. Because for a long time in our country's history, we confused the 2. We would see transgender people as gay or vice versa. And so it just is, it provides a multitude of help in this process. And it also helps our clients share more specific information that may pertain to gender identity, because if we talk about it during sex, it might not come up. Then ask about personally described definitions. So terms are great as long as it helps us understand what somebody means when they say, I am, fill in the blank here. They're not so great when we use them to assess somebody's physical characteristics and then try to assign those labels to them. So let somebody lead the conversation about their identity and the particular terms or descriptive definitions that they use for it. I don't know if you guys have a gender history in your system. If you guys use Epic, I know you have access to it. But if you do have access to a gender history, use it and use it for everybody. Because like I said, right out of the gate, we all have identity. Just because we are a cisgender person does not mean that information is any less important than if somebody is a transgender person. So it's important, if you don't have a gender history, I'm sure we can work with you in terms of helping support that process. But typically a gender history includes how they identify in their gender, how they identify in their sexual orientation, what pronouns they like to use or that they use, and then what organs they have. So for instance, it's important to know if a transgender female has male genitalia and a prostate, as well as it's important to know that a trans male still has a uterus. So having all of those things are typically on a gender history. And then I can't emphasize enough, you're probably going to see this on many of the slides, communicate gender history appropriately with other caregivers. So make sure that if you're sharing gender history with other providers, that it pertains to culturally appropriate treatment planning and so forth. So in terms of referrals for, do I have a slide here? Yeah, there it is. Let me talk about this one first. So in terms of people seeking services in conjunction with medical help to manage a chemical addiction, there is AA or NA, but a lot of the people within the transgender community are not so much on board with the religious aspects of those 2 programs. I'm not going to say none of them go to AA or NA, but I wanted you to know that there were alternatives, and you may already know about these other ones, but I wanted to talk about them and why they're important for this population as well as for their mental health. So Smart Recovery. Smart Recovery is kind of a hybrid. It not only is a self-directed program similar to AA or NA, it does not have the religious influences, and where it intersects with the mental health process is that it follows a CBT or cognitive behavioral therapy process in terms of identifying what the situations were that cause addiction to to be triggered. And in those situations, what are the things that you feel and think, and what are the things that make you feel and think most intensely, and working through how to balance thoughts to make sure that those triggers or the intensity to use can subside by moving from thoughts and feelings that increase likelihood of use to thoughts and feelings that will either make it more manageable for them to avoid use or decrease the impulse to use. Refuge recovery is another religious based recovery program like NA or AA or NA, but it draws more on Buddhist philosophy. And I say Buddhist philosophy, not Buddhist religion, because Buddhism in its true form is less about practice and more about personal insight and growth. Now, in terms of mental health care, people that work well with clients that are dual diagnosis, mental health and chemical dependency. Myself, I work at the Sexual and Gender Medicine Clinic at CentraCare. It does take about 3 months to get on my schedule at best. So if somebody is in a place where their needs are less immediate, I might be a really good option for them. And the reason why it takes so long to get on my schedule is because my primary role is in supporting hormone and surgical care within our clinic. Other people within CentraCare are Kayla and Molly. Both of them do a really good job. Molly and I have known each other for many, many years, and as long as I've known her, we've collaborated, consulted, and successfully helped clients through addiction. Molly also used to work as a therapist with Recovery Plus, which is CentraCare's chemical dependency program. So she has that really great background. Kayla comes to us. She's recently new to CentraCare, but she did a year of supervision underneath me as a postdoc. And so, in that time has had a lot of experience and education on working with transgender people with dual diagnosis experiences. And then at the Village Family Service Center, Sam Schofield or Nen Bohr do really great work as well. I lead a community collaborative of mental health providers, and Sam Schofield and Nen Bohr both regularly participate in that as well. So I think that's the end of my slides. Yep, that's the end of my slides. So maybe at this point, what we can do, if there's time, is turn it over to any questions or clarifications on any of the things that we just talked about.
Yeah, and if people want to chat some in, I know Heather and I have a couple as well, so maybe go ahead and chat them in. We can.
Okay, so one, I'm trying to decide which one. I'll start with this one. Often, you see people in their, whether it's on Echo or when they say their name, they'll put their pronouns after their name. And I mean, obviously we never want to make assumptions about anything, but is that a good identifier of gender, or is that just, you should never make that leap, or is there any, I don't know if you understand what I'm trying to say, but.
So I think that is a great practice. If you and everybody on Echo wanted to start doing that, I think it's good. Is it a good indication of gender? No, because if I put my pronouns behind my name, they, them, it wouldn't tell you anything other than I want for you to refer to me as they, them. So using pronouns to make that connection to gender isn't necessarily the wisest or going to be the most accurate way to assess gender. The most accurate way to assess gender is, I see that you use they, them pronouns. What does that mean about your identity? Or what does that mean about what I should know about your identity?
Perfect. Yeah, I think that's more helpful.
Yeah, that's more helpful. No, go ahead.
Okay, so no, mine's a long one, so you go.
Well, I'm just wondering if you could comment a little bit more on kind of the intimate partner violence and why that is so so high in this population as compared to other populations?
I think, I mean, you mentioned it a little bit with
Yeah.
depending on how they're viewed it within the relationship, but is it, I guess I want to piggyback on yours.
Okay.
Is it because they're in a relationship where it was a societal kind of imposed upon relationship, like by society, you are born female, you need to be with this male, and now there's more violence? Or is it within gendered relationships where they've, genuinely chosen their partner?
Mhm. So the research is no different whether or not the relationship configuration is a transgender person with a non-transgender person versus both the people or all of the people in the relationship are transgender themselves. What the research is indicating is that when we hear a message that is negative about who we are, and then one of two things happens, one being something proves that it's right, or there becomes a need to protect myself, safety issues, then I internalize that message and then it becomes my thought to myself, not somebody else's message to me. Then once that message is internalized, then I will, or anybody will, act accordingly in terms of.
Sorry about that.
That's okay. I didn't know what was going on to begin with. But anyways, once we internalize that message, then we own it. So we act less than. We expect people to treat us less than. And that's where the relationship violence comes in, is that it's very easy to mistreat somebody with physical violence or emotional violence or verbal violence when they will accept it, or when we have been taught that it's okay to treat somebody with disrespect.
Perfect.
Does that answer your question?
Yes.
Yes, very much so.
Okay.
One of the things that, and unfortunately, I know somebody that recently committed suicide, and in the transgender community, I'm just wondering what is being done on the prevention side for that issue.
So everybody that comes through care within our clinic gets the Columbia Suicide Risk Assessment. So even if they're not talking about suicide, we have conversations about whether or not they're thinking about it, have thought about it, and how close they've ever gotten to completing it. That helps us create a culturally competent treatment plan that addresses having those conversations that are necessary to empower that person, one, to feel better about themselves, to reduce their mental health risks, align their relationships so the relationships are more supportive, or a whole host of other things. Medically, if somebody scores high on the Columbia Suicide Risk Assessment, they then get either scheduled with one of our medical providers that can provide mental health management, or they get referred to somebody that can do mental health medication management, because a lot of times it's the intensity that we're trying to get away from. If we lower that intensity, a lot of things happen treatment planning wise that we don't previously have access to. When people's intensity is lowered, they're more likely to follow through with doctor's recommendations for care. They're more likely to come to therapy. They're more likely to utilize therapy because they're not underneath the weight of all their emotional intensity. So medication, management is a big part of it. And then within center care, we also get notifications when people are in the ER because they're not doing well emotionally. And so we always follow up with them and make sure that they have the aftercare that they need to address those things.
Okay, so I'm going to ask my slightly long question that kind of has a patient case attached to it. So personally, and I'm going to apologize because I will mess this up. My sibling, born physically female, and I have been there since the day this child was born, so it's very complicated for me. Is transgender, identifies non-binary, they, them, has a very different chosen name from the, given at birth name. And we've had a lot of chance to talk about this very openly, and which is grateful. I'm grateful for that opportunity. And my husband's on here too, so he can speak to it too if he wanted, but that's helped me learn. And I think my big question is with all of the different places you had commented on with, development, whether it's, childhood, pre-puberty, puberty, and obviously knowing that they're a half sister of mine, and knowing how they grew up in a very different environment than how I grew up. We've never lived together. The amount of trauma they have endured, and how our dad and their mom approached this child as a child growing up. And we've talked about this non-binary and how even they feel it came out of the treatment of all of this childhood. And so I wonder, is that common? How do you approach that? And, in our addiction clinic, we get ACE scores on patients. Like, do you do that and track that?
Yes. So during a mental health assessment, we do track ACEs. However, it's very inconclusive as to whether or not ACEs are indicating of the emergence of a gender incongruence. Oftentimes, when I ask somebody, what are your earliest memories of your gender not matching up, or feeling uncomfortable when people refer to you as said birth assigned sex? I would have to say there's probably just a handful of times in the last 23 years I've had somebody answer anything other than one number. Now that's too coincidental for me. And that number is 8. And even more coincidental is that 8 lands flat firm in between 6 and 10 when that developmental period is happening. So, there's no research that's conclusive that links trauma to gender identity or gender incongruence. I don't know if that was the question you were asking.
The reason I asked it was just because how they spoke about it. And again, having the ability to speak as a sibling is a little bit more, at least to me, I get a lot more forgiveness than, a random person I'm meeting, and how they identified that evolution and to the point. How old? They are 21, 22, right around that age currently. And so that's why I asked, because it's very interesting. And then the other question that kind of follows that is, I have 4 children. My oldest is 12, my youngest is 5. And they are amazing in this. They understand, my sibling, they are really good at the communication. They never get a pronoun wrong and love correcting us. And it's interesting because they go to a Catholic school. They have never been taught this, never been educated. And do you see that as, we see it in addiction world, people are more accepting as they're younger. Do you see that? And how do you kind of foster that forward before society ruins them?
Yeah. Interestingly enough, a lot of the people in the age group that you're talking about socialize more outside of school than they do inside of school. And it is a social commentary now about transgender. Whether it's positive or negative, we're hearing about it. And so, they might not be talking about it at the Catholic school, but they're certainly talking about it with their friends outside of school. They're reading about it, they're hearing about it, they are interacting with other people, especially for people that are doing these computer-based games and whatnot. But how do we foster that? We just keep letting people grow up in a world that allows this to be a conversation. Unfortunately, most of us on this call didn't grow up in that world, and so we're going to struggle, and that's okay. But eventually, as there becomes more people and the conversation continues, we'll get it too.
Okay, I'm gonna ask that question that Erin just brought up. So Erin is one of our nurses and has been working with for years and years and years. And I know we're at time, so people need to go. I get that. And if Troy, you need to go, we can respect that and maybe have this conversation offline. But your thoughts and opinions on nature versus nurture. I'm sure you get this question all the time, and we're probably waiting for it. But
Yeah. So, yeah, I think that's the original conversation about transgender is just nature versus nurture. And I think we've really covered a lot of it when we were talking about ACE's effect on the emergence of gender incongruence. Now, in terms of specifically addressing nature versus nurture, I don't know if that subject comes up in a clinical setting, if I really ever really just address it, because what I've learned is that when I do address it, it gives it validity, even when I'm just disagreeing with it. But if somebody does want to have that conversation, like, well, allow that conversation not to be had, I definitely share my thoughts on the inconclusive research on the matter, and that the majority of the places that conversation comes up for people, nature versus nurture, is when they're really typically invested in debunking or invalidating the transgender experience. And if that's where somebody is at, is anything I'm going to say going to matter?
You know, as you were speaking, I just love that, because I think early on you mentioned that it can't be about us. It has to be about the person we are working with. And I think the nature versus nurture, if people are arguing that, that's so they can feel better about making boxes. I'm saying boxes because Kurt hates the word silos, but I think that's very helpful.
Yeah.
Truly, because I love the unicorn thing so much, that visual. So I think it definitely takes out the true argument of nature versus nurture.
Mm-hmm.
Troy, we really appreciate the time you put aside for us. I think from the tech or from the things we were getting on the chat, everybody really appreciated your talk and felt it was really helpful. So thank you so much for your time.